Hi, I'm Dr. DrRodz, and we're going to be talking today about your carpal tunnel. Where is your carpal tunnel? What is in there? How do you get a carpal tunnel syndrome? And what can you do about it? All of this brought to you by the miracle of the interwebs. Okay, so let's talk about the carpal tunnel. Where is it? Well, it's located right where your wrist joins your arm, right where I'm drawing my little line here. What we're going to do is we're going to come out over on the side here and draw a cross section of your carpal tunnel. This is the skin of your hand, right about there. Okay. So what's in your carpal tunnel anyway? Well, it starts off with a wall here. You've got a little bone over by your thumb, and then another little bone over by your pinky finger, and then you've got some bones of your hand, the back over here. Now recall that this is going to be the palm of your hand up here, and the back of your hand down here. Okay. And then what else is there? Well, let's see. You've got these tendons that are running up and down your arm, connects the muscles back here with your fingers up there. So we're going to put those tendons in here. We're going to represent them with little dots. It's kind of like looking at a bunch of spaghetti seen end on. Okay, you got a bunch of tendons over here, right? And what else is in there too? Well, what else is in there is your median nerve, which is a big nerve that feeds your hand and lots of other things, all right? It runs right about here, right up in the middle there, goes up there, and gives off a little branch of this big chunk of muscle here. The median nerve is going to provide sensation of your thumb, your index finger, and your middle finger typically. It's also going to provide strength to this muscle over here so you can move your thumb. And let's call that the median nerve. Okay? And then over on top of all this, on the palm side of this whole business, is a layer of connective tissue that kind of runs and hooks the tops of these bones together. And this layer of connective tissue is called the transverse carpal ligament, or TCL. Sort of runs kind of like that, sideways. All right, runs over there. And the purpose is just to keep everything inside the carpal tunnel if you flex your wrist. And that's what it looks like when we're born and we're happy little babies. Okay? But as we get older and our ears get bigger and our beard gets longer and longer and longer, what happens, or what can happen at any rate, is this transverse carpal ligament can start getting thicker, thickens up. And as it thickens up, it starts to push inside your carpal tunnel, and it can actually start pushing on the median nerve and do exactly what I'm doing over here. It can actually thin out and squeeze that median nerve until only a teeny little sliver of the median nerve is left. Okay? And what happens when that happens? Well, when that happens, you start getting numbness of your thumb and your index finger and your middle finger. You can start getting weakness of the muscle over here. Okay? So that is the carpal tunnel syndrome. It's caused by squeezing of the transverse carpal ligament on that median nerve right about here. You can get a lot of pain in this region. You can get numbness of your thumb, your index, and your middle finger, and you can get weakness of the thumb area. Okay, so now we have a carpal tunnel syndrome, and we've already gone through the non-operative management like physical therapy and stuff like that, and we are now trying to figure out what to do. The next step along the line after the splints and the injections and the physical therapy has always been open surgery. Basically what you do is you make an incision kind of in the palm of the hand right about here, and then we're going to move it over to our diagram here. Remember, this is cut right about over here, and this is the palm of your hand over here and the back of your hand over there. This is the transverse carpal ligament, right? And your median nerve is right here. Okay, so basically what you do is you come in through the skin of the palm of the hand, through the tissue underneath the skin, find the transverse carpal ligament, very carefully section that, and then expose the median nerve. So what you're doing is you're kind of coming in like that with your knife, making a careful incision in the transverse carpal ligament. When you do that, the transverse carpal ligament tends to spring back, so you get a nice little opening. And then you see your nerve, and then eventually as time goes by, the nerve gets all plump and juicy and happy again, and with any luck, it'll start working. So that's your open surgery. The difficulty with open surgery at this part of the hand is this, that if you look at the skin of your hand right about here, and you compare the thickness of the skin of your hand on the palm of your hand to the thickness of the skin of your hand back further up your arm, this is much thicker than the skin over here. And that's because you got to recall that our mammalian ancestors were all quadrupeds, and then we invented this innovation called bipedal gait, and then came language. Don't even get me started about fire. But the point is that the skin over here still retains some of our ancestral thickness of the hands, which makes it not healed nearly as well as the skin over there. So if you make an incision in the skin of the palm of your hand over here, it's not going to heal nearly as well as you make a little incision over here. Same incision, same knife, same everything. This one's going to heal a lot slower and than this one will over here. So people said, gee, there has to be a better way. And we're going to talk about that better way in just 1 second. So now we're going to talk about the endoscopic approach to this carpal tunnels. And it all starts like this. Some smart guy figured out that really all you need to do in order to decompress the median nerve here is to cut the transverse carpal ligament right about here. And then if you did that, it would pull back either way. You wouldn't have to bother with the skin, and the median nerve would then be happy, get all plump and juicy, and start working again. So that's what we're going to talk about, is how this guy came up with this really neat idea. All right, so let's review some anatomy. The median nerve, remember, is going to be running through the wrist into the palm, giving off that little branch. Okay, it's going to be covered up by the transverse carpal ligament here, and that's what's actually pushing on it. So this guy said, let's think about it. If we just made a little incision right about here in the wrist, nice well-healing skin of the wrist, and then we put an instrument underneath everything, underneath the transverse carpal ligament, on top of the nerve, and then just cut it from the inside, maybe it would work. And in fact, he went ahead and developed a set of instruments that did exactly that. If you look at these things, it's about the size of a chopstick. It's about 5 or 6 centimeters long. There's a little endoscope, a little light pipe in the tip of it there, so you can see what you're doing. You see a little thing over here, looks like a knife. Well, that knife can actually flick up, just like that. So the idea is you put the instrument in through a little incision you make but way back in the wrist here. You pass it underneath the transverse carpal ligament, and then you deploy that knife. And then as you pull it back, you cut the transverse carpal ligament. It exposes the median nerve, and your operation's done. And that is the principle of an endoscopic carpal tunnel release.
Okay, so the usual disclaimer, you watching this video does not make me your doctor. Use common sense. If it hurts when you do that, don't do that. And always keep in contact with your own healthcare provider throughout this. So we are all over the web. We have a very active Facebook page with our patients. We are big-time tweeters, and we are way into Instagram. To see more videos about anterior cervical discectomy surgery, general spine info, our blog, or to contact us, just hit us at DrRodz.com.